working? Okay. Hi, good morning, everyone. I'll be presenting the results from a cross-sectional study that we did at the Faculty of Health Sciences, looking at student perceptions of the effectiveness of additional language tuition in the MBCHB program. The research team consists of Dr. Joel Claassen from UCT Afrikaans and Nederlandic Studies, Mr. Zukile Jama, who's now based in UWC's Department of Xhosa, and then two medical students, myself, Zahraa Mohamed, and Stephanie Roach. Okay. So I'm just going to start with a little bit of background in terms of language barriers and how they hinder healthcare provision. So language discrepancies between patients and providers have been shown to reduce quality of care given, and this is quite an intuitive finding. If the provider and the patient can't understand each other, it's very difficult for the healthcare worker to provide effective and appropriate treatment. In South Africa, with 11 official languages, barriers exist all over the healthcare system, and most healthcare professionals, excluding practicing nurses, are unable to communicate in any of the indigenous languages. In a study performed at the Red Cross Hospital, they found that most interviews weren't conducted in the patient's home language, and there was no use of an interpreter. And patients reported that language barriers, along with cultural factors, contributed to a barrier much more than structural or socioeconomic factors, with 70% of participants reporting dissatisfaction with communication during patient-provider interviews. Then further than the quality of care is the effect on patient rights. There are various ethical issues involved, which I'm sure you can imagine, in terms of things like informed consent and the use of fellow staff members and family members, sometimes random other patients in clinics, as translators in sensitive conversations, like, for example, HIV counseling. As argued by Hussey, placing this burden of multilingualism on patients to learn English poses a threat to cultural diversity and the dismantling of Western cultural domination. In addition, given South Africa's history of racial discrimination, there's a very strong negative relationship between previous disadvantage and English proficiency. And this means that the decreased quality of care and the compromised rights of patients who don't speak English often act to further marginalize illiterate and uneducated members of society. So the UCT Health Sciences response has been to introduce career-orientated language learning courses for Afrikaans and Xhosa, and this was introduced in 2003. So in years 2 and 3, we have weekly language tutorials, and then we're assessed through objective structured clinical evaluations, or OSCEs. And then in years 4 and 5, there are language components in the general medicine and pediatrics modules, which also contain a language OSCE. For pediatrics, it's only Xhosa, not Afrikaans. Okay, so going on from that, basically the motivation for our study was to evaluate students' experiences and how effective UCT's intervention is in equipping graduates with communication skills that are necessary for working in our context. And we also aim to compare Afrikaans and Xhosa to evaluate whether the program is producing graduates that have equal competencies in both Afrikaans, a language historically used in higher education, and Xhosa, an indigenous language historically marginalized across South African universities. We did a descriptive cross-sectional questionnaire, including mostly closed-ended questions. We chose a random sample of 120 UCT MBCHB students per year in years 2 to 6, and we sent out the form on Google. So we sent it out to 120 students in each year, and it was available on Google Forms in the month of March last year. It was collected into an Excel spreadsheet through Google Forms, and then analyzed through Stata. Okay. So I'll just start by looking at some of the sample characteristics. So this was our response. These were our response rates. You can see, so from each of the years, you can see the 4th years were the highest, likely because my clinical partner Stephanie and I were in 4th year at the time of the study, so people probably recognized our names and were more likely to participate. Then the next 3 slides show quite a similar picture about the level of Afrikaans and Xhosa that students had prior to starting the MBCHB program. So here you can see that over 35% of students identified themselves as fluent in Afrikaans, compared to only 11.5% in Xhosa, although the proportion of home language students was the same in both. This next graph shows the prior language exposure that students had had. So you can see that almost 100% of students had some Afrikaans exposure, compared to just over 40% for Xhosa. And the majority of the exposure comes from primary and high school subjects. You can see here, yeah. Okay, these pie charts look at what number language Afrikaans and Xhosa are for the students that answered. So dark blue is first language, orange is second language, and gray is third language. So you can see for Afrikaans that for the majority of students, Afrikaans is their second language, compared to Xhosa, where it's their third language. This is of the students that answered, of course. Okay, then the next section that I'm going to speak about is the student perception, so how people answered these questions. This is just a screenshot from the questionnaire to show how we asked it. So you can see, for example, it says the class sizes are conducive to practicing the language with tutor assistance, and then students could grade it from strongly disagree to strongly agree. Okay, so here you can see how students agreed or strongly agreed to each of the factors, and if they facilitated learning. So you can see that in every language, except attention to cultural issues, students found that the factor facilitated learning in Afrikaans more than it did in Xhosa. It's striking that in every single category, more than 50% of students said that they didn't think the factor facilitated learning in Xhosa. And the same is also true for Afrikaans for non-standard varieties, attention to cultural issues, and validity of assessments. Okay. We then moved on more to the practical outcomes of language teaching or learning in the program, so how it kind of translates into the clinical sphere. Okay, so you can see for both languages, the majority of students said that they spoke to few patients in their home language. We didn't quantify what few meant, so it obviously can be quite subjective, but if you can look at the other two, you can see that more students speak to all or many patients in Afrikaans than they do in Xhosa. Okay, we then asked students what the barriers were preventing them from speaking to patients in their home languages. So we mentioned lack of confidence, lack of encouragement from senior colleagues, feeling uncomfortable to try when fellow students are not speaking the language, lack of language ability, and if students don't think it's necessary if the patient can speak English. And you can see that lack of confidence and lack of language ability are the two major barriers for medical students to speak to patients in their home language. The results are kind of similar in Afrikaans and Xhosa for each reason except for language ability, which seems to be much more significant for Xhosa than for Afrikaans. You can see it's the opposite for I don't think it's necessary if the patient can speak English. For Afrikaans the level is higher for Afrikaans than for Xhosa, which likely reflects high incidences of Afrikaans and English bilingualism in the Western Cape. Okay, this next part shows the areas in which students feel comfortable speaking. So this is just basically like splitting up a normal patient interview into different components. So greeting the patient, taking history, that just means asking questions about the problem, examining the patient, understanding responses, and then explaining investigations and treatment, and breaking bad news. For Afrikaans, more than 60% of students can greet, examine, take a history, and understand responses, but then there's a significant drop to explaining investigations and treatment, and less than 10% of students felt comfortable breaking bad news sensitively. This is lower than the proportion of home language Afrikaans speakers, so it likely reflects discomfort generally in having these kinds of conversations, not necessarily related to language ability. For Xhosa, you can see students are much less comfortable in every area except for greeting. The biggest difference, though, is in understanding responses. Almost 60% of students can take a history, so they can ask the questions when a patient comes in, but only about 25% can understand responses. Okay, so just to kind of summarize the results is that firstly, students enter the MBCHB program with much more exposure to Afrikaans than Xhosa, and therefore a higher level of language proficiency in the former language. Secondly, students are having difficulties using Afrikaans and Xhosa with patients in a clinical context, with more trouble in the areas of examining, understanding responses, explaining investigations and treatments, and breaking bad news sensitively. Thirdly, lack of confidence and language ability are the major barriers to speaking to patients in their home languages. And then fourthly is that the results for Xhosa and Afrikaans vary very significantly, both in terms of student perceptions of factors that facilitate learning and in terms of how it translates into clinical interactions. We obviously should think that this might be related to the first point of the background of student language ability. Okay. So some of the recommendations that we'd had so far is possibly to split teaching more in terms of student levels when they enter the MBCHB. So perhaps there should be some kind of assessment near the beginning of the program and to tier students depending on their language ability. It seems that nearly everybody doesn't think that there's enough time for language tuition. Then there also needs to be a review of the course and the assessment outcomes to be more appropriate for students' communicative levels, i.e. you want the assessments to better reflect how students can actually communicate in the real-life context. And then possibly also more of a focus on practical interactions in class or even language immersions to build confidence in language ability. So I just mentioned the SSM here. It's possible for students to basically do a 4-week immersion during their special study module in second year. And anecdotally, people do have a lot of confidence coming out of those sorts of settings. So potentially there might be some role for this. I'm just going to end with some of the limitations of the study is that the uptake wasn't very high, as you saw in the first slide. I think there were 20-something students from 6th year, and the 6th year students have the most clinical interactions. Obviously, there's selection bias in terms of the type of study that we're doing. And then we also haven't separated our analysis into the years or the prior language ability, which we might still be doing and could give a lot of insight in terms of how different students with different language ability, their needs might be different and how we can start to address them. Cool. That's it.
Thank you so much. Are there any questions from the audience?
Thank you very much for that presentation. I just have 2 questions, and one of them, I'm sorry, I might have missed something, but you mentioned that one of the programs, Afrikaans, was not integrated into the learning. It was only Xhosa, and I'm wondering why that is, because we know that some of the communities here in Cape Town are mostly Afrikaans speaking. And the second question is, with the difficulty of learning, I know that colleagues, when the students say some of the colleagues are not using either Afrikaans or Xhosa, it makes it difficult for them to learn. But have you looked more into senior colleagues? Because I know the uptake, the response there was very low for senior colleagues sort of mentoring or facilitating students to speak the language. But I found that for me, when I had an initial senior colleague mentor, I was told that for respect, I need to put students at a distance, and then that will facilitate learning because they'll respect me and I'll therefore teach better. And then I changed the mentor, and he told me that, listen more to students because they're not, people occupying chairs, but they're actually human beings. And that's when I felt more comfortable in facilitating my students in a multilingual environment. So the role of the senior colleagues actually matters a lot. I know they might not have recognized that, but if senior colleagues really facilitate that kind of learning, then we coming in, because we're just learning and we just want to survive in the environment and know how to thrive in the environment. If senior colleagues perhaps facilitate more, mentor more, and encourage more of the multilingual learning, then that might also help them learn better. Just a comment. Thank you.
Should I answer first or wait for the question? Okay, can I actually ask Dr. Claassen to answer the first question about not having Afrikaans in PEDS?
Good morning, everybody. I'm going to project the language divisions are basically housing humanities, and we are invited by departments to participate and contribute to different sections and to the IndiCHP degree. So it's also dependent on each department in health sciences and how they want to equip the students and participants based on the course itself and based on the structure of the curriculum. So it's actually just dependent on the departments that, and of course their budgets that have an impact on the fact that entirely from year 1 to year 2. So it's a process. It's been 10 years, so it has been progress, as you can see. So I think it's something that does take time, and
And then I'll just answer the second question about senior colleagues. So the reason that we included this as one of the options is because we had experienced this ourselves, and anecdotally we'd heard this from other students, and that even though if you have the language ability, even if you're a home language speaker, it's like there's a lot of discomfort to use that home language if your senior colleagues are not using it. So although it didn't really come out in the study, that does seem to be, clear.
Thank you very much for your presentation. I was just wondering whether students haven't had some challenges with regard to patients who do not speak either Afrikaans or Xhosa. Number two is that are students being taught Xhosa, academic isiXhosa, or the spoken Xhosa? Because there's a difference between academic as well as spoken Xhosa. And how would then this affect their interaction with patients? Thank you.
Okay. So for the first question, there are issues with patients who don't speak either language, so either other South African languages or patients who are coming from other parts of Africa often. So obviously UCT chose to focus on these two languages because they have a high prevalence in the Western Cape. What I didn't include in the presentation was our last question was if students think it's important that we do teach these languages, and I think about 85% of students said that they do think it's important. But a lot of the comments that came from that was, from the people who said that it wasn't important was, well, as soon as I leave the Western Cape, what am I going to do? It's not going to be useful for me. I'm still going to have troubles communicating with patients in other provinces, for example, for internship. So that definitely is an issue, speaking with patients in other languages. But obviously UCT chose the two languages that have higher prevalences in the Western Cape. Then in terms of the type of Xhosa that's taught, it is spoken Xhosa. It's a communication course, yeah. It's not academic Xhosa.